Today, let's talk about behavioral and psychiatric emergencies. And on the behavioral side, these abnormal behaviors can stem from just a number of different sources. So be aware, be cognizant of all these different sources, even if they're genetic, they're biologic, or they're sociocultural, or they're psychosocial, maybe PTSD, maybe instability at home, or there's, again, those biologic, those genetic factors. So these behaviors, we need to also identify the cause of the behavior at hand. These patients require a real team effort, so it's us coordinating with other public services, other health services. There are crisis intervention teams out there. They're specifically trained for these populations and de-escalation and connecting community resources, things like that. CITs were initially developed for police departments, but they have expanded, and there are a number of EMS agencies who provide CIT training for their own EMTs and paramedics. And then on our side of things, thinking about maybe if you have policies or protocols for this already, but thinking about transport of these patients to alternative destinations and not necessarily the emergency department. And there are somewhere around 2,700 communities across the U.S. that have some sort of CIT program. So if you don't, you can look into the training, 40-hour curriculum. And again, developed for police departments, but has been adapted for EMT and paramedic EMS use. And again, this is going to be a team approach. When contacting these patients, it's us, it's law enforcement. There are these mobile crisis teams with maybe social workers available to you. There are different resources. So the aim here is to control any emergency situations, but to coordinate resources for this patient and get them the proper care that they need. As paramedics, our primary roles are to identify the specific behavior and where it's coming from, what's causing this. And we also need to choose how we engage with the patient. So we need to quickly identify and engage, and then through our assessment, through our conversations, we can determine which community resources are needed for this specific patient. And for these patients, we're going to be seeing them in crisis. So when we get there with our crisis interventions, paraphrasing and summarizing, defining what they're saying to you, making sure that they know they're being heard and that we're fully hearing them and what they're saying. We can get them into a private environment that is best, that is safest for them, providing our support, our empathy, and with that we can get them on board. We can get patient commitment. So when we're making a plan, we can get that commitment, we can get that agreement from the patient. And when making a plan, limit options and alternatives. If we offer a dozen options, it's going to be difficult for this patient to really commit to one. But if we just offer, if we limit it to 2 or 3 options, the patient is much more likely to agree to one of them and can more easily understand the options. We also need to practice therapeutic communication, and this is very important with this patient population. So we need this creating this mutual understanding, right, through verbal and non-verbal cues, showing respect, showing empathy, and building trust with this patient is vital. And everything we do is going to be patient-centered, right? And the advantages of our therapeutic communication, we're going to be able to build rapport, build trust with our patient. It is easier to de-escalate and makes things safer for us and those around us. And then it makes things much simpler in gathering assessment data, especially accurate assessment data and history data from the patient. And during your interview, during your assessment, we've got that therapeutic communication going both ways, but we are actively listening and we're allowing processing time for the patient when we say things, allow them to actually process it. So silence is okay. When we ask questions, make sure they're open-ended, just not yes/no questions. It's tell me about what's going on right now. Tell me about today. Tell me about what you're feeling, what you're hearing, what you're thinking. And then summarization. We talked about kind of repeating back to the patient so that they know you're listening, and everyone's making sure that what is being communicated from the patient to yourself is being clearly heard and understood. And we're doing all of this with empathy and validation of what the patient is going through. Now, there are some specific challenges for this patient population, because not every patient is going to be receptive to your presence. Because remember, and keep this at the front of your brain, often when we are called out, when 911 is called and EMS is called, it's often because the patient is in a crisis state. So they've, say these psychiatric disorders, they've had this diagnosis for years, and today they are in a crisis state. So that's the lens through which we're viewing these disorders, where we should be viewing it as this chronic disease, and the patient has had this for years, has diagnosis for years. We're just seeing them at their worst today. So when you're dealing with these more challenging patients and difficult encounters, trying to engage uncooperative patients, or different avenues we can go down there, but acting with empathy, acting with respect can help engage. And then you might need to manage their silence, their non-responsiveness, try to build trust and rapport with them. And just using that reflective listening, validation, therapeutic communication, and that will help you with these more difficult and challenging patients. What we're definitely going to avoid when speaking with these patients is being judgmental, being dismissive of anything they're saying, giving them false reassurance, no matter what it is, what it looks like. We're not there to give them advice in these situations. So avoid advice, avoid just these false reassurances just to get what you want. And we're going to keep our questioning to a minimum. So excessive questioning can kind of erode trust with the patient, and it kind of makes you come off maybe a little judgmental. So we're trying to limit our questioning to the exact points data points we need, the histories we need. All right, so let's dig into some specific behavioral and psychiatric disorders. These disorders are going to be defined by the DSM-5. We're up to the 5th edition now. This classifies and has diagnostic criteria for all these behavioral psychiatric disorders. Just know that your patient may have signs, symptoms of more than one condition, and may be diagnosed with more than one condition. And from our end of things, typically our patient care for these patients is completely supportive. The common ones here, especially seen by paramedics, we'll talk about one by one: depression, anxiety disorders, PTSD, bipolar disorder, and schizophrenia. Depression is that of depressed mood. You'll see loss of interest in just varying aspects of their life. Difficulty sleeping, feelings of worthlessness can progress to suicidal tendencies. Often co-diagnosed with anxiety, and there are theories of what causes depression, leads to depression. There are genetic theories out there, genetic explanations, also chemical explanations, differences in serotonin, dopamine levels, or norepi levels in your body. With anxiety, it's kind of this persistent, or this feeling that's of dread or fear or pressure that's not related to really anything that's going on around them. Anxiety disorders can manifest in a panic manner, but just know that about half of anxiety attacks, panic attacks, do not include what we think of the telltale, like hallmark, hyperventilation that manifests in many different ways. So our treatment for most anxiety patients is going to be supportive. And your general anxiety patient, typically we see them in that panic stage, but they have a history of anxiety. Maybe they're having a little anxiety in the moment when you're with them, so just a little excessive anxiety, excessive worry, but restlessness, irritability, if they've been complaining recently of just difficulty sleeping or restlessness, all symptoms of just generalized anxiety. Then we have obsessive compulsive order, or OCD. OCD is just a step further than anxiety in this disorder. The patient's going to have these stressful thoughts, these obsessions that kind of motivate them to perform these repetitive behaviors or these compulsions. OCD can interfere with normal daily activities, or maybe not. So the worse it gets, the more it interferes. And then in children, OCD may be overlooked because we might not realize that their behavior is unusual. Might just kind of play it off as kids being kids when it's actually a sign of OCD. So a little bit harder to diagnose in children, or overlooked in children, and then diagnosed later on in life. They have taken OCD and kind of put it into two boxes here, with OCD, one being fluctuating with one's anxiety, that's mental illness, and then in OCD, that's a personality disorder, so obsessive compulsive personality disorder, in which these traits seem to be just persistent over time, so they don't fluctuate. So a little bit of difference in diagnosis, not so pertinent for us as paramedics, but good to know the background information. Then we have PTSD, or post-traumatic stress disorder, type of anxiety reaction to severe psychosocial events. It can be one main event, one big event, or it can be cumulative. Many different types of PTSD and diagnostic criteria and treatments. Symptoms generally come from four categories. Include intrusive symptoms, avoidance, arousal and reactivity symptoms, and then cognitive and mood symptoms going along with PTSD. Then bipolar disorder is this severe up and down biphasic emotional disorder, in which we've got manic phases and we've got depressive phases. So that pendulum is always swinging. So sometimes the negative mood takes over for a period of time. Sometimes the positive mood takes over for a period of time, creates manic states. Our goal is to modulate the two and balance the emotions. For schizophrenia, there are a handful of theories as to what causes schizophrenia or how it works inside the brain. Leading hypothesis is the dopamine hypothesis, in which it's just abnormal neurotransmission in parts of the brain. So your schizophrenic patients may be prescribed medications, and their drug therapy goal there is blocking dopamine receptors and blocking serotonin receptors. So this abnormal excessive neurotransmission is controlled a little bit more. Symptoms-wise, a schizophrenic patient might be reporting hallucinations or delusions. They might have disorganized speech, odd behaviors, and remember, this is when our schizophrenic patient is in crisis, right? So this patient has a schizophrenic diagnosis. They may be on medication for it, and they may be able to live their life day to day without any symptoms, and this is just a crisis moment for them, and that's when we see these patients. So be mindful, we are seeing all these patients in a crisis mode, but for schizophrenic patients, be asking about these possible symptoms and looking for signs of these. Now, there may be times where we need to step in a bit more aggressively, and medication treatment is required. We'll start with sedative medications. And our sedatives, we've got these different states, right? Our kind of emotional reactions, and as we cause depression to the central nervous system, as we slow down the central nervous system, we've got this super tense patient, right? As we give a little bit more, different medications, right? Do we just want to calm them down a tiny bit? Do we want to make them sleepy, a little bit drowsy, or do we want them completely sedated asleep, right? So where in that central nervous system depression can we get, or do we need? What's our goal? For this, we've got a category of drugs that are called sedative hypnotics. Those are our benzodiazepines, I think our antihistamines, like Benadryl, and also barbiturate drugs. So our benzodiazepine drugs and our barbiturates both bind to GABA and stimulate GABA receptors. But the benzodiazepines and the barbiturates, even though they both bind to GABA, they're binding in different spots on GABA, which create different responses. Barbiturates are heavier sedative drugs and carry much heavier side effects than do benzodiazepines. And for our agitated patients, when we come into contact with an agitated patient, utmost importance, what is the cause of that agitation? Could be something mental health, behavioral health-wise, could be substance abuse, but could be something physiologic. Changes in blood sugar, for example, seizures, for example, right? Or it could be behavioral, it could be substance abuse. So we need to identify the cause, and that will drive our treatment for the agitation. And we have a rating scale for agitation, which is the behavioral activity. So it's a behavioral activity rating scale. Bars goes from a 1, where the patient is just difficult to arouse, all the way through 7. They are violent. They require restraint, whether it's chemical or physical. So when you're looking at the higher scores, those 6s, those 7s, that's when we're starting to think maybe we're going to be giving a medication to control this behavior. Here's a sample protocol for agitation and sedation, and it is based on that bar score. So there's no sedation required until we get to a bar score of 5, and thinking first off just verbal de-escalation, right? And this protocol also has these oral medications. If the patient is cooperative enough to take an oral medication, we can go ahead and do that. And once we get that bar score, the high range, the 6 and the 7s, now we're thinking our benzodiazepines, maybe haloperidol. We're starting to think chemical restraint via medications. Further medical treatment, medication treatment might be required. That bar score of 7, again, that's just this example protocol. So that bar score of 7 is the highest score. So definitely thinking benzodiazepines like midazolam, also considering ketamine at higher doses. So ketamine at that sedation dose. Here this protocol starts at 4 milligrams per kg IM. So a lot of these medications you might need to be giving IM just because of the severe agitation. So we just talked about ketamine at these sedation doses, that 4 milligrams per kilogram IM. When it comes to using medications to manage acute agitation from psychoses, we typically reach for haloperidol or Haldol or droperidol, and both these can be given IM. Haloperidol 2 to 5 milligrams, and your droperidol 5 to 10 milligrams. When that acute agitation is just agitation and it has nothing to do with psychoses, we can reach for one of our benzodiazepines. The two common ones we'll reach for is Ativan and Versed, lorazepam and midazolam. Your Ativan, 1 to 4 milligrams, can be given IV. Your Versed can be given IM, also IV. Versed can also be given IN. So if you're giving it IV or IN, typically start at 2.5 milligrams. If you're giving it IM, we will up the dose a little bit to 5 milligrams. While assessing and obtaining your history, your patient may be prescribed some antipsychotic medications, usually given to patients who with diagnoses of schizophrenia, bipolar, and used to manage their manic states. Any patients with diagnosed psychoses, and then we'll be using our medications for acute agitations. Antipsychotic medications are categorized into two flavors, typicals and atypicals. Your typical antipsychotics, their primary mechanism of action is they are blocking dopamine receptors in your brain. So they're going after dopamine, blocking those dopamine receptors. So our drugs like haloperidol, Haldol, and droperidol, those are typical antipsychotics. Those are dopamine blockers. Your atypical antipsychotics, newer drugs, they block dopamine receptors, but they also block those 5-HT serotonin receptors. So your atypicals, just newer psychotics, or antipsychotics, excuse me, and they go after both dopamine receptors and serotonin receptors, whereas your typical antipsychotics are only going after the dopamine receptors. Your patients with bipolar disorder may need some heavier medications at home to control and manage those manic states. So they might be on benzodiazepines at home, other antipsychotics at home, or lithium. Lithium is a popular drug for more severe forms of bipolar disorder. So it's a mood stabilizer, going after dopamine, serotonin, and glutamate as well. It's a low therapeutic index medication, so these patients are being monitored pretty closely while they're on lithium. And finally, some antidepressant medications that your patients may be on. Popular ones are SSRIs, selective serotonin reuptake inhibitors, and they do exactly that. Serotonin is released into that synapse to bind to those 5-HT receptors, and these drugs inhibit the reuptake of serotonin, so it leaves more serotonin in that synapse for more stimulation of those serotonin receptors. There are tons of SSRIs out on the market you may run into. Common ones like Zoloft or Lexapro. Prozac was an early one, so sertraline or Zoloft is very common. There are also some newer ones, some atypical SSRIs like Wellbutrin, Cymbalta as well. You may have heard of, but all of these are your selective serotonin reuptake inhibitors. And of course, if you have any questions, please let us know.